religious experiences, it doesn't really begin to touch what happened when I joined SNL. It's been a nonstop process, but for an incredible cause, and as Al was saying, we've seen great progress. We still have a long way to go. I hope to share with you today some of the lessons learned, and really trying to look at some of the low-cost, feasible, and effective interventions that we've learned about, and then to sort of suggest that we still need to learn more, in particular about how to integrate these into our programs. So I'm going to talk about, do community-based newborn health packages work? First question that we had to address, because there was, as you heard initially, there was a great deal of skepticism about what could be done outside of neonatal intensive care units. And then to look specifically at the high-impact interventions, the ones that really have an evidence base of effectiveness and feasibility in low-income settings. And then lastly, to talk about what should be the research agenda for future newborn survival and health, as Al had also mentioned. Well, this slide actually coincides with my midlife crisis religious conversion, because on my 50th birthday, I left the University of Chicago on a plane bound for India, and I went to an NGO that was started by a doctor named Ave Bhan and his wife Rani, and they had just a couple of years before published the first paper that showed that there was a way that we could save newborn lives with simple community-based interventions. And I went to evaluate this program, and it's my very first job with saving newborn lives. And not only was it the beginning for me, but quite honestly, this was the beginning for the movement. It really opened the eyes of the world. And I think looking back at the investment that the Gates Foundation made in saving newborn lives program, it was clearly based on evidence that something could be done and needed to be done. So I'm just going to go with the evidence here now at this point. Home-based newborn care was the package that Dr. Bond described. It involved just a couple of bullets I've listed here. Community health workers went and identified pregnancies. These were selected from the villages, and they were mostly literate, but some non-literate. They went out and identified pregnancies and made visits to counsel women about birth preparation. They attended deliveries, and they provided neonatal resuscitation with a bag, first with a tube and mask device, and then later with a bag and mask device. They then made postnatal home visits. They made quite a lot of visits. And when a baby was small, they made extra visits. And they also were trained to identify and treat with oral and injectable antibiotics babies with signs of severe infection. The results of this trial that were published in 1999 in The Lancet demonstrated that over a 3-year period of time, from the baseline to the third year, there was a 62% reduction in neonatal mortality. And this is a startling number, and really did promulgate global awareness that here's an intractable issue, that now we have something that we can do. This slide is now an attempt to show you where we moved in as saving newborn lives and looking at this evidence. So obviously, yes, this works, but it worked in Ave Bhan's NGO. Does it work elsewhere? Can other settings, other places, other people do something similar using fairly similar methods? And so this is a depiction of 4 such studies that were basically replications in one form or another of that initial experience in search in India. And the first is called Anchor. It was a project that was done again by Dr. Bond, but looking at at implementation of this by NGOs, not by his group specifically. The second was done in Bangladesh by a group from Johns Hopkins University, supported by, and these were, all of these were supported by SNL. And then in India, there was a similar model, not identical, that used community mobilization and had home visits by community health workers. That was in Shivgar, very, very rural, very poor area with extremely high neonatal mortality in Uttar Pradesh. And then lastly, in Pakistan, using government health workers, but with a lot of inputs from the project in an area called Hala. And I just would call your attention to the, just in red across the bottom, you can see that in all of these trials, there were significant reductions, again, that were seen in neonatal mortality, ranging from not 62, but as high as 54 down to 30%. You'll notice that the 30% was in the area, was in the particular area in Pakistan where they were using government health workers as opposed to project workers. I should note that the latter three were all very robustly designed, cluster randomized controlled trials. The first is actually a before and after design. But in SNL, we, in our first phase, we undertook a total of 36 research studies. Hard to believe now to look back at it. Basically trying to build awareness that these simple solutions that had been pioneered by Dr. Baum, solutions for the three killers, could be feasibly delivered and have impact in these low resource settings. So what happened after that at the global policy level was a lot of eyes opening up and thinking there is something that we need to do, and we need to actually get behind this. And so a number of agencies, including the UN agencies, UNICEF and WHO, worked with a number of various partners and developed what you see on the right as a joint statement. It's entitled Home Visits for the Newborn Child, a Strategy to Improve Survival. And this was really spurred by the evidence base that I just showed you, that something could be done in low resource settings to improve newborn survival. So I've listed here, there's sort of ways to look at this, positive and negative. Clearly on the positive side, which I think outweighs the negative in a minute, this spurred many countries and donors to take action for newborn survival. Country policies began to change, programs began to develop, both governmental programs and NGOs. But there were some issues, and I want to highlight those for you as well. Not all these policy steps end up being completely positive, and we have to sort of think about that sometimes when we're assessing policy decisions and how to influence policy decisions. In this case, all of these studies were largely efficacy studies. They were not effectiveness trials, which means that it's sort of what you can do in the best case scenario, but it's not clear if that's doable in real life. We'll note that there were a lot of political wrangling in WHO between maternal health and child health communities during this time. And it ended up being unfortunate that much of the maternal content that was put into this original document was not there in the end, and that was unfortunate. And then it was also noted that while this was just a general guide, there really was not a set of implementation tools, and particularly not real guidance on training, supervision, monitoring systems, and logistics management, all the ingredients that really have to be there to make this work effectively. So I'll take you to phase 2 of sort of post-joint statement. And I want to tell you about 4 studies. These are all, they're all cluster randomized controlled trials, all again from South Asia, with the exception of now Ghana, you'll see on the right. And these were were trials that were constructed to be in existing health systems, not projects undertaking this. And I won't go through all the details, but just to note that they were in Bangladesh, Pakistan, and India. They were using existing cadres of health workers and largely existing systems. In the second column in Pakistan was really done by the same group in the same region as the previous Pakistan study, but at about 3 times the scale. So it was really much more about what it takes to deliver it at scale. And I would note to you, I'm sorry I don't have the references here. I intended to get them in and did it this morning, but I can make the references available in a version that goes out to you. So just, I apologize for that now. But to note the New Kent's Ghana trial, the far one on the right, I just got a copy of the online version from The Lancet yesterday with this paper published and a commentary. And so the paper, what you will notice then now, if you go down to the third row of looking at the impact on neonatal mortality, you see that there were reductions in neonatal mortality, but they were not as large as what we had seen in the previous more efficacy trials. In the paper that was has just been published from Ghana, the principal investigator, the chief author, Betty Kirkwood, with her colleagues, conducted a meta-analysis of these 4 trials, which are considered to be more effectiveness, if you will. Some implemented well, some not so well, but basically they were effectiveness trials. And in that meta-analysis determined that there was a 12% reduction seen with, I should say that was statistically significant in the meta-analysis. And then we're looking again at just this question of community health workers making home visits through actual programs. So I think there's a lot of lessons here. We could talk about this at some length, what this means. And in my last slide, I will come back to sort of what I think are some of the things we need to think about here. But clearly imagining that we have to worry and be concerned about the strength of implementation. In some cases, we have to think about, and there were some examples here where in fact the intervention didn't necessarily match up with the cause of death structure. And so, for instance, as many births were happening in facilities in Ghana, they were still doing volunteer home visits, but did not have a program to address referrals and quality of care facilities. So these kinds of mismatches, as well as maybe not always the best implementation strength, are issues we have to think about as we go forward in our program. I want to turn now to the evidence on how to prevent neonatal deaths from the known killers. So this is a slightly different track, but something I wanted to cover. We do have evidence-based interventions, largely from what we've learned in developed countries, that has also been examined in low-income settings. Corticosteroids, I'm not sure if all of you know this, but the lung maturation is quite late in babies, and so babies can be born prematurely with immature lungs and essentially succumb. They don't survive because of that severe lung disease. And administering corticosteroids to the mother who's in preterm labor a few days before, a day or two before delivery, can cause a rapid maturation of the lungs, and the babies actually that were doomed to die will live because of that. And so it's been found that through some analysis that we don't have data from low-income settings, but in middle-income countries, corticosteroids are now known to be associated with a 53% reduction in preterm mortality, that is mortality of babies less than 2 kilograms, with a significant reduction in morbidity, including the brain and the intestines. However, the coverage, we don't have great data on this, but the coverage appears to be very low in low-income settings. It's been estimated lower, not more than 10%. It's scattered. Some countries are better than others. Some regions in some countries are better than others. But it also is estimated that if we could achieve high coverage, that would include first-level health facilities and district hospitals, that we could save probably 500,000 lives that would otherwise die. Also, we know we have evidence-based interventions for preterms in terms of management. And by and large, the simple intervention, kangaroo mother care, which I assume is practiced here by humans as well as by kangaroos, but we, the world has adopted the term kangaroo mother care even in settings in Africa where they had no idea what a kangaroo was. But it has been found through some more recent meta-analysis to be actually be associated with about a 50% decrease in neonatal mortality compared to conventional care, which includes incubator care. So this is actually better than the technology that we tend to think of as being necessary. And there have been associated major reductions in morbidities such as pneumonia and low weight gain and hospital stay, and it really increases breastfeeding as well. Still, we find the coverage remains low in low-income settings. Possibly, in many cases, we find that doctors and nurses think of it as a kind of low-tech, poor person's intervention, and they'd rather have incubators. And so we really have some challenges. Birth asphyxia, as Al said, is an important cause of death. And I just wanted to cite an example that we were involved in Indonesia, where evidence generation was associated with some major policy change. The question was asked, can neonatal resuscitation be effectively provided in low-resource settings? We know this is a standard part of high-tech care. And in Indonesia, the community midwife cadre delivers a substantial amount of babies in community settings. But their training did not involve training in neonatal resuscitation. So we worked with the government to come up with an operations research project testing whether or not the use of a resuscitation device, in this case you can see it's a tube mask, which is a very low-tech type of device. But we found that there was a reduction in improved neonatal mortality, and furthermore, the midwives were able to do it. The government was convinced that this is something they should do, and it's been rolled into national policy. And I should say that since this was done, this was about 8 years ago, the more sophisticated bag of masks that's used more universally has become the norm. It's become the standard. That has become cheaper and more affordable. Well, I think most of you probably have heard of Helping Babies Breathe. This is the steps in neonatal resuscitation that most of us trained in high-tech settings were one of the more complex programs. I trained in neonatal resuscitation program, NRP, by the American Academy of Pediatrics, which really focuses on advanced resuscitation, and it includes chest compressions and drugs if the heart doesn't start. But it's always been known that the first thing that has to happen in resuscitation, and the thing that really works the best, is ventilation. It's just making sure that, first of all, the baby's stimulated, is dry, warm, and then gets breathing assistance if the baby's still not breathing. And it's been determined that breathing needs to start within 1 minute, so everybody has to be prepared to be able to do this. So the Helping Babies Breathe program was developed by the American Academy of Pediatrics in collaboration with a number of partners, including the state, and now it is being rolled out. I'm not going to say it's at scale, but it is rolled out in countries that, last I heard, the count was somewhere between 30 and 40 countries. USA has supported a big part of this, but it's multiple numbers of groups that are engaged in this process. And there was recent a paper published from Tanzania that is one of the first papers that looked at a before and after study of the impact on mortality, which had not really been established in this. And they found that there was about a 47% reduction in day one early neonatal mortality, and there's also about a 25% reduction in fresh stillbirths. So babies that clearly were not really stillbirths, that had been labeled stillbirths, when they were actually offered resuscitation, they turned out to live. Now I wanted to talk about neonatal infections, just a couple of slides here. I know that you've probably heard about chlorhexidine. It's an antiseptic, and it was hypothesized a few years back that despite the WHO recommendations of dry cord care, that even in dry cord care practice, babies were exposed to pathogens that could enter the cord. And so 3 trials were conducted in Asia. And here's the results of those trials. It shows the relative risk. You can see here's the first study that was done in Nepal, and I'm just going to show you these 3 in Bangladesh and Pakistan. Without belaboring the point estimates there's been a meta-analysis done, and overall, when this is averaged out, there was a 23% reduction in mortality, that is all-cause mortality, among those who received chlorhexidine compared to those who did not. This is an intervention we can talk about. It's being, there are a number of countries that are rolling this out. Nepal is taking this to scale. Other countries, a couple of countries in Africa, such as Nigeria and Ethiopia, and then there's interest also in Pakistan and Bangladesh, and I hear there may be interest in some of the Pacific region as well. I want to finish the interventions by talking about management of neonatal infections, and just, I don't want to belabor the detail on this slide, except to say that community health workers, from the work that has been done, it's been clear that community health workers are capable of identifying using simple algorithms in newborns with infection, and also can provide antibiotics, oral and injection, or all injection. And this has been demonstrated from several sites in Asia, and there's a trial that Al mentioned in Ethiopia is demonstrating the same, although that trial is not finished. This is important because the WHO guidelines still call for 14 days of penicillin and gentamicin in the hospital. And in settings that we've seen in South Asia, even something as high as 2/3 to 80% of babies identified with sepsis counseled to go to the hospital. Even in Pakistan in the trial, given free access to care, free transportation, free treatment, they still refuse to go. So we have to really make efforts to move newborn sepsis treatment down to the community level based on some of this evidence. And we are doing, as Al said, a simplified antibody trial to try to determine which regimen or regimens that would be feasible to deliver in community settings, that would be acceptable to families, are close to the same effectiveness as the standard regimen. And that trial will be finished later this year. I just want to make a couple of observations on what I say are lessons about care seeking. We used to think that after Abe Bang's work that we felt, okay, babies are considered vulnerable by families. They won't take them out of the house to seek care. We can only reach babies to treat them for sepsis by having community health workers make home visits, and families can't identify danger signs. We have to have the visit 2 or 3 times in the first week of life. Without sharing the data, I can tell you that we have seen that families are willing to bring sick babies to health posts and health centers for treatment. But it does require, first of all, awareness of the problem that we're trying to deal with, awareness that there is a solution and that solution is available. And that means commodities and quality services are available close to home. We've seen this actually in Africa and in Asia. So I really think that we need to base our future estimations of how we deal with newborn sepsis on this emerging reality. And then I also want to note that families and communities are deeply concerned about maternal survival. And when we talk about newborn survival, I think, for many reasons we need to link mothers and babies. But it's been apparent to me that if we talk about newborn survival without really putting it in the context of maternal survival, that communities don't hear the message and heed the advice, nearly to the extent as if it's contextualized with mothers. So there are many programmatic and policy reasons to do this and advocacy reasons, but communities, I think, are important. Well, we know what to do. Here's a slide that says that these are just the interventions I mentioned earlier. The evidence-based interventions we call 3 times 2 plus 1. The plus 1 here is basic newborn care. All babies need hygiene, warmth, breastfeeding, clean cord care. Babies that can die from asphyxia, first of all, they need prevention and with good quality obstetric care, which I haven't mentioned, and then treatment with resuscitation. Low birth weight babies, we talked about steroids and kangaroo mother care. We have that evidence. And infection, we have evidence of clean delivery and now chlorhexidine, and we know that the antibiotics can be made available closer to home, and we're working on getting that out. We still need to learn how to deliver many of these interventions. We know the evidence, but the how questions are still a little bit to be addressed. I just wanted to note that I have 2 slides left. Innovations. SNL, in addition to sort of the work that I described, I know that the Brennan Institute is working on some innovations, and we are as well. I just wanted to mention the 3 just sort of headline, and one is the one I mentioned earlier, the simplified antibiotic regimen. Another is a simple fetal heart rate monitor that can be used in very low resource settings without electricity, and then also using mobile phone-based perinatal death audits. This is being done in Uganda. And then we've also been working with Laerdal Company and the American Academy of Pediatrics to modify neonatal bag and masks, because bag and masks are hard for less experienced resuscitators because the mask leaks. It's really quite hard to maintain that seal, and that makes the ventilation ineffective. But a new version of this is an upright. I wish I had one with, it's a vertical bag and mask. And we're going to be looking at this and doing some studies in simulated resuscitation to see to what extent that actually improves performance as well as skill retention. The last slide, this is just for you to see quickly. This is what Al referred to as our research priority setting exercise. 200 questions were identified as important questions to researchers and programmers in the newborn health field, and then a systematic process using a standard set of criteria were used, and something on the order of over 100 experts were asked to rate each of those 200 sub-questions, and then they were ranked, and this is the top 10. And I'm not going to go through them, and you can have this copy. I ask you not to disseminate this because there is going to be a paper coming out, but I think it's interesting to see. What's most instructive to, I think, for us, though, is to get back to this idea that we really know what to do. We're still needing to learn how to do it and how to do it effectively. And so what you see in the last column is the domains were delivery, or discovery, develop, and delivery. And the 9 out of the top 10 were in delivery science. So it's clear that this is really where we have to go. So in conclusion, I just want to say that there is solid evidence of what simple interventions can save newborn lives, averting most of the world's neonatal deaths. Intervention effectiveness requires strong implementation, that is, availability of services, commodities, and care seeking. We must modify and adapt interventions to the rapidly changing context, as Al said. In some cases, that means focusing more on referrals, on quality of care at facilities, linking facilities to communities, and then really ensuring an integration of newborn and maternal interventions and delivery strategies. And lastly, I want to say, as we move forward to implement, we definitely need to learn how to deliver these interventions effectively at scale. So that concludes my presentation. Big questions at this time, Beth?